And I think it's a good idea to discuss any problem that may be on your mind as it comes up. I think, are you used to being interrupted when you're mid-flow? I always think it's very good to settle something that's on your mind immediately. And
stop. Go on.
Also, if it's not too inconvenient for the questioners to speak into the microphone. I'll see if I can loosen it up a little bit. Now, Dr. Michael Mew is our next speaker and is probably well known by his surname as being one of the major names in the development and advancement of our orthopedic concepts. And I think, are you the third generation, Michael?
Yes.
Yeah, well, third generation, Dr. Mew, thank you very much.
Okay, thank you very much indeed. So, I've been working for some time on a concept to try and put everything together so that I can understand how all the separate component parts of much of what we're all doing can act together as a single cohesive unit. I've switched it off. Okay, I've called the concept Craniofacial Dystrophy. This is the reference I published in the British Dental Journal as an opinion article. So, please do have a look at it. When I published it that year, it was one of the top 5 reviewed articles in the British Dental Journal, which I got a little letter from. It was very impressive. And they do encourage me to publish something again, which of course I will go on to do. Now, I can ask why we're all here. Well, we all know something's wrong, don't we? Because we're all, we are the non-mainstream, we're the alternatives, we're the outsiders. We all know that. So, and I think that, we all know that, growth can be manipulated and we know we'd better start young. But within here, there's a huge variance in what we're actually thinking. Now, if we follow the scientific principle, none of us can prove anything. We can only disprove things. And little groups like this tend to be very friendly and we tend to be very nice. And there's always this hesitation to want to say, well, I think you're wrong on that. To take someone else's philosophy and break it down into the different elements in front of them or with them and break it up. It seems unpolite, it seems a bit rude, but that's what I do intend to do. And I've been gently working my way around. And I'm sorry if I sound a little bit abrupt at Brendan Stack's meeting, pushing the similar point, but I want to be a bit abrupt. I want the truth. As I said, as Richard said, I'm the third generation. My grandfather was introduced to Weston Price. Now I'm 3 generations down, and we still don't in that time really have found all the answers. Well, it's about time we did. It's about time we put everything together and really understood what's going on. Now, what I think that we could probably most of us agree that the people out there on the left, they're very easy to treat, probably don't need much treatment, come to see osteopaths, come to see orthodontists very rarely. If you do treat them, they'll treat fantastically. They're the ones that you show on your presentations. They're the ones that you have on your promotional material on your website. The ones in the middle, they're our bread and butter. But most of them come back. So if we treat them orthodontically, they'll come back needing more orthodontic work. If you treat them osteopathically, they'll come back needing more osteopathic work. They're your bread and butters. You get to know the family. You know what they do. You help them out when they have problems. But you're not really making them better. You're helping them. And the ones on the right here, well, they're the ones you don't want to see. Best send them on to someone else because they're going to be a disaster. When they walk through the door, you go, oh, I think you're a particular type of patient that I'm not the best with. go somewhere else. I've got a list of other orthopaths here, take them. Now, so what I'm trying to make friends, malocclusion, facial form in general, well, sleep apnea and TMD, ENT, neck and lower back problems, other issues. Well, we could probably throw TMD in there. I'm not going to do TMD. It would take lecture by itself. Now, John Flutter has a very good phrase. Says, I see crooked teeth, I know they're not well. These people are not well. That's the type of girl that's going to go on to get, she's got poor body posture, you can tell. She's probably going to have sleep apnea, she's going to have ENT problems, she's going to have crooked teeth. Now, I think it's only by changing people that dramatically that you're really going to cure them, put them back into that first category. Because we need to cure people. We're not here to make people a little bit better. Now, if we look at the hierarchical nature of any science, we need the etiology, epidemiology, pathology, treatment and cure. Well, in orthodontics, we don't have anything but treatment. We've ignored the complete rest of it. We don't know what causes it, so we say it's genetic. That means we don't need to have a pathology. And we're using permanent retention, so that means we don't need to have a cure. And if you send a patient to 10 different orthodontists, you will get 10 different opinions. Now, if I went to see a cardiologist and I got 10 different opinions, I'd be very upset. You know, I would wonder what the hell was going on. But, you know, it's only teeth. So that I'm trying to put it together with these other things. Now, I'm wondering if they could share an etiology and pathology, because it would kind of make sense. We're looking at this one body system, so we should be able to find the same etiology and pathological process. Now, isn't it interesting, as I alluded to earlier on with my question to Tim, that throughout evolution, until we became civilized, we had no malocclusion to speak of. Only about 250 years ago, malocclusion existed in the 10–15% of the privileged individuals. Of course, that dates back to about Egypt, really the ancient Greeks. Till 250 years ago, most people, the bulk of people, had pretty straight teeth. Of course, the other 5,400 species of wild mammals have all got perfectly straight teeth right now. And if you go to any indigenous populations alive today, see someone who walks out the African savanna, Australian bush, the Brazilian rainforest, they have perfect posture and perfectly straight teeth. They never seen an orthodontist, never had a pair of retainers, they're fine. You know, you've got examples with these Inuits here. Now, the history of malocclusion, this is a logarithmic scale. Now, I'm going back 220,000 years to when we were first anatomical humans. That's a long time. And of course, what we've got here is a logarithmic scale. Now, interestingly, that line there is when we took our normal X-rays. So anyone who's taking and showing me KEFs, you'll have to understand that I'm not particularly interested. I think that it's, you know, when you've got foundation stones are in the wrong place, you're really going to struggle to understand things. It's a bit like when we thought the world was the centre of the solar system, and to understand how the stars moved, you needed these hierarchical linear lists of do this in this situation, do that, and a little bit like a cookbook, a little bit like orthodontics is prescribed now. Because unless you have your focus in the right place, you don't know what's going on. You don't understand it. And I think KEFs are causing a great damage to the profession. And of course, you know, all of these people had their wisdom teeth in place. They had spaces behind their wisdom teeth. My fingers fit on my hands. My legs are down the same length. I should have space for all of my teeth. It's nonsense that the wisdom teeth have just somehow been outgrown. It shows a gross misunderstanding of evolution and the speed of evolution. It's nonsense. We should have clearly all our teeth, 32 of them, working and in function. And of course, well, where did malocclusion come from? You know, all diseases, genetic diseases come from somewhere. If we look at sickle cell anemia, that's a genetic disease. Anyone who has sickle cell anemia can trace a relative back to one of the first person that got it. Simple. And malocclusion appears wherever, whenever, to whomever becomes civilized, in complete isolation in all of these various different groups. Ask anthropologists and archaeologists what causes malocclusion, and they'll go, oh, civilization. Of course, we know that, it's written in the textbooks, well understood. Whenever you find a body that's got more than a few trinkets, they start getting crooked teeth. When they've got lots of trinkets, they've got more crooked teeth. Remember, these were the privileged groups, that top 5%, who could live the life of milk and honey from some time ago. Whereas we took those Inuits off the ice, they had perfect occlusion. They came off the ice when the Canadian government granted them citizenship, went into social housing with food stamps, and within two or sometimes one generation, they had the same levels of malocclusion as the indigenous population living in similar lifestyle. And of course, we've gone from about 5% malocclusion, which are the traumas, syndromes, possibly even some cranial strains, to 95% malocclusion over this period of civilization. That's a sea change. It's massive. And I was interested in Weston Price and his observations, but I really don't think it's the consistency of the diet. You've got lots of individuals who are starving in Africa or on terrible diets who have perfect facial form, perfectly aligned teeth. So it clearly cannot be missing vitamin, because these people have lots of missing vitamins and develop perfectly well. So what is it? I mean, what's causing these problems? Because clearly we've gone from 5% to 95% malocclusion. This isn't a small change, it's a massive change. It's affecting every single person in this room. And unless you're that 5%, we still don't know the cause today. That same 5% through the history, who have always known the cause, is the only one we can diagnose today. For your kids going in to see the orthodontist, they'll have no idea. Well, we might amongst us. Now, well, clearly muscle weakness can have an effect. It can have an effect at any age. You have a stroke at 80 years old, your face will change. This young girl had muscular dystrophy. This is a modern norm. And again, I told you how I was suspicious of those modern norms earlier on, overlaid on someone with muscular dystrophy. She's biting together on those teeth there. So that ancestral ideal would probably be further up and forward than the modern norm. Well, clearly a change in the mode of breathing can cause a problem. And I'll come to that because I actually don't really care where the air goes. And I think we need to have our nomenclature right, and we need to stop using this term mouth breathing. It's confusing. It's a bit of a red herring, and I'll come to that in a second. Cranial strains. Well, you know, it's not my area, but I wonder how cranial strains can actually be responsible for change from 5% to 95%. These guys lived in a very traumatic situations, our ancestors. And they didn't have crooked teeth. I don't know if they had cranial strains, but the teeth were perfectly aligned, perfectly.
You did say, Michael, that actually she found 85% newborns had cranial strains.
Yeah, no, I'm interested in that. But I don't see the change. I'm wondering what could have caused that change to go on. Now, I'll come to it, and I'm open for debate. But I want debate. I'm not just taking it verbatim. Because it needs to be, everything needs to be questioned. I'm a nothing, you know, that's how I was brought up at home. Now, as you can imagine, no, never.
So Mike, does that mean you didn't believe everything your father told you?
Of course not. No, never. But gently, he has bent my mind round. So we've got a massive change in posture. I mean, this is common. And of course, when I come back to that breathing, Harvold did some great research. He blocked the noses of these monkeys and got great change. But he also did a more important piece of research in my mind, where he placed nothing more than a piece of plastic sutured in the roof of the mouth. That made them drop their tongue, and they went from a group of monkeys with perfect facial form and occlusion to a group of monkeys where every single one of them had gross skeletal deformation and malocclusion. Nothing more than putting something on the roof of the mouth. Now, that wasn't changing the mode of breathing, but it made them drop the tongue down. Now, if you breathe through your nose, your tongue may or may not be on the roof of your mouth. But if you breathe through your mouth, clearly your tongue has to be down. Lips apart and your mandible lowered. So the mouth breathing has an influence, but it's really not the mouth breathing. It's not where the air goes, it's where your tongue is. Where your lips are sealed. The mouth being closed or not closed, the teeth being together or not being together. So let's stop the use of this term mouth breathing. Let's start saying open mouth posture. This is more definitive, and terms are important. Now,
can I just ask that? Is anyone going to address biochemistry of breathing through the nose and breathing through the mouth?
I'm not today, but it would be interesting to do at some point. Yeah, I've been to many Buteyko lectures. Yeah, and they do talk about that, but of course that's not this field at the moment. Yep, I have to narrow it down a little.
Absolutely.
Now, of course, I think we've gone to an effort change. We've gone down to about 3 or 5% of the effort our ancestors did. So that's a huge reduction in effort. This is a normal bite. That is a normal Homo sapien bite. If anyone talks to me about canine guidance, I'll say, well, that's pathological. And it is, because that's normal. It's like anteropen bite, because the curve of Spee, as they went forwards, it wore away. What's called a helicocoidal wear pattern, so it's worn down like that, and it comes up like this on the side. For 220,000 years. Well, come, the pyramids are only 10,000 years ago, and we think that's old. No, not even that. Farming's only 10,000 years ago. This is so much longer than that. Thousands upon thousands, generation upon generation upon generation, all like that, all like that, all like that, all like that. Then all of a sudden, a blink of an eye, we've changed. You know, when we're talking about intercuspation, when we're talking about how Tim was talking about how the teeth fit together, now, there was a very nice smooth plane. You had a working and non-working side continuous like a grindstone wheel, because they needed to eat for so long in the day to get calories on board. Because there's massive change from this hard, low-calorie diet to this incredibly soft, high-calorie diet. We spend no time eating. If you have a Mars bar, well, you don't need to eat so many meals in that day. You've got your calories on board. Don't worry. You don't have to do so much effort. So clearly, masticatory effort, body posture, are important. Yeah? That mandibulolingual posture, I think is particularly important because we know if you drop your tongue down, from Harvold's work, that can have a massive change on your facial form. Well, if you've got a blocked nose, you've got to breathe. What starts out of habit, what starts from necessity can easily become habit, particularly when you're learning your gait. When you're learning to stand up straight and you're having to open your mouth to breathe, when are you going to change? Because you've now learnt. You've built your proprioception. You've formed your comfortable muscle lengths. A friend of mine, an osteopath, John Silverstone, has a patient locally to him who's got multiple personality disorder. He can tell which personality she's in from her posture. When you develop that, when you start standing, if you've got a nasal blockage, even transient at the time, you're going to form that body posture for the rest of your life. Now, soft tissue balance. Well, of course, we've got a lot of debate about lack of early breastfeeding. The science isn't really clear, and it's good science. crap science in dentistry and orthodontics in particular, but breastfeeding, there's some good science. And I would love it to be more. I think there's more interest in my mind now on the transition from a suckle to a swallow, how that occurs, the concept of baby-led weaning, effectively. And of course, cranial strains, and I've put that down at the bottom, but I'm open to challenge. You know, I want to know more. I want to understand more. I want the truth, the whole truth, and no dogma. Thank you very much. Now, so I think this is what goes on if you've got the tongue on the roof of your mouth. If you've got your teeth together much of the time. So you've got your indirect forces, you've got your direct force of the tongue, indirect force of the bite. There's only one way you can grow. The face grows forwards. Great. You know, those are that first group we talked about. But no, if you don't, if your tongue's down and you don't got that mechanical force pushing up on the maxilla, your face is going to drop down. It's going to remodel a little bit. Because, of course, the mandible coming out of the skull, past all those soft tissues, there's only one place it can come out, really, isn't there? Because there's only so many structures, there's so many vital structures, you're going to have to remodel that bit, so it's only coming out in that one place. Remember that, it's important. Now, Marcotte noticed that we always hold Nasian above Begonian. Now, I think, personally, that that's because we're social animals. If I walk into a room and I feel more superior to everyone, I'll tip my head up a little bit and, you know, that's I'll be. If I feel I'm equal to everyone, I'll have my head like this. And if I'm feeling a little inferior to everyone, I'll drop my head like that. Now, that's just my thoughts on it. It's just a guess, but we're social animals, so we'll present a head. But now, what's that? Oh, dearie me, gone ahead. What's that done to the neck? Really going to mess the neck up, isn't it? In exactly the same way that we see. Now, of course, what's happened to the mandibular length? Well, it's not changed. I don't think I make mandibles any bigger. Sorry, I agree with the research that suggests that. And everyone who says, oh, how are you going to translate the mandible? I'm going, it's a rotation. We're rotating. The maxilla's dropping down and back. The mandible's dropping below it. Now, of course, what's happening is the functional length of the mandible's reducing massively. And of course, it's massively in the front, crowded incisors. At the back here, lack of space for the wisdom teeth. Exactly what we see. Now, so effectively what's happened is this is an ancestral normal. This is a modern normal from the Bolton group. We're nice normals, to be honest. So neither of those have got problems. But of course we've dropped down. And most interesting, look at where those molars are. Because of course they had a wider arch. And if you've got a wider arch that's further forwards, your molars are a lot further forwards. That's a lot more tongue space. You get an extra 2 tongues in there. Now, anyway, as the face drops down and back, I think that any further than that, and that's where we're talking about cranial strain patterns, that's where the body starts to say, I've had enough. That's where the body starts to say, I'm giving up. I cannot compensate much more beyond this position, and that's why we start getting problems. And of course, if you've only got so much face, as it's getting longer, it's narrow, it's going to get narrower and shallower. Well, of course, what's that going to do to the airway? This whole tongue's coming down in on that airway. It's going to reduce your airway. So as the face melts down, the maxilla and the tongue are descending. They're pulling the maxilla and the tongue down into the airway. There's going to be less space for the dental arch, the teeth, that's what we see, but there's also less space for the tongue and the airway. And of course, airway is quite important to you. Now, as Hilary is demonstrating, Peck did some research where he basically put clothes pegs on the noses of students. And the first thing they did was open their mouth. The ones that didn't went blue and died. No, they didn't do that. They dropped them and of course, if you try that, even sitting there now, you'll find that as you drop your mouth open wide, it's a little bit uncomfortable because you're pushing that jaw back into the vital structures, which is what I mentioned, remember, earlier on. Now, so the next thing you're going to do is tip your head back. But then remember, we're social animals. So about a couple of minutes later, maybe up to 5 minutes later, all these individuals then did, eh. So the first thing, one, hey. Well, that's what we see, isn't it? In everyone. And of course, we've got various different patterns, and we can talk about ascending or descending, but, you know, I want to learn from you lot. That's my hunt, that's my task, is to get more things. I went to this website to get it, because sometimes I find websites of people who have learnt it non-professionally, give the best explanations, and I do recommend this website, fixtheneck.com. It's really quite good. Do go and have a little look. She seems to explain it nicely, and she breaks these into body types, and I want to learn more about this. Now, we need to do compensations. So earlier on, Tim was talking about compensations. I'm talking about compensations. So you need to breathe, clearly. There's only a couple of things you can make in these postural compensations. So you can move the head and the neck, as I'm describing we're doing, and we can move the mandible and the tongue. So what I think is happening is, rather than this flat world thinking, where orthodontists have clearly always thought of class 1, class 2, class 3, what's really happening is this is ideal. We're dropping down to class 1 malocclusion like this. We're dropping down to class 2 malocclusion this. We're dropping down to class 3 malocclusion like this. Now, Bjork described it as these rotational patterns really nicely, but by taking class 1 or taking normals as what he saw in that time, it's a little bit confused. It's a little bit like these guys trying to map the stars out, thinking the Earth was the centre of the solar system and the universe. It was a little bit confusing. But it does make a lot of sense, this. Now, the one thing people often ask me is about these deep bite cases. Well, I say, well, if you want to analyse a deep bite case in occlusion, then you can analyse them in occlusion. But that's not how they are all the time. A deep bite case is also a bilateral posterior open bite. Depends how you want to look at it. But if you're going to ask them to bite together, you've asked them to go into an artifactual position, and you're going to be left a bit confused. If that's what you want to do, that's what you want to do. And also, you always see in deep bites that maxilla drop forward and back like that. But that's, again, another subject. It's like TMD. So I think lots of problems are all associated because a face that doesn't work, a face that doesn't fit together, a face that's not the right shape, doesn't work properly. It doesn't. It has a certain architecture that was evolved over millions of years. And if you mess with that, it's not going to work properly. And of course, the real big one, of course, here is sleep apnea. You know, you've got your other problems here. TMD, again, we're not going to go into. But sleep apnea is a big one because, of course, sleep apnea has been implicated in cancer, obesity, diabetes, coronary heart disease. You know, a lot of the modern world diseases is clearly implicated by sleep apnea. And I think that it's, you know, I go to lectures on sleep apnea and people say, oh, well, we've always had sleep apnea, we're just diagnosing it better. And I say to them, well, maybe we didn't always have sleep apnea, and it's only arriving now as we can diagnose it with this modern society. Can you prove me wrong? And they say, no, can't. So I say, have you been to some really indigenous populations and seen what the levels of sleep apnea are? No. Oh, well, that would be a good idea. So, you know, here we go. My father did some research on identical twins when you could still do that type of thing. And I think we would agree that of the twins on that left-hand side, the twin on the lower has less mandibular prognathism. So I'm not saying his mandible's back. What I'm saying, it's his drop down like this. So it's dropped down more than his brother. And as we will now reveal, afterwards we got significant change. He was treated by an orthodontist who was well aware he was in competition. You can't really do research like that anymore, so I still present it. But of course, there's another class 2. She was waiting for surgery. Yeah, I could get the teeth sort of more organised better, and I think I've made changes that will help me with that. But you know, it's a great result. I'll show another one. And here's a class 3 that I've treated more recently. That was an 8mm reverse overjet. She's now class 2. So I'm now going to treat her as class 2. And I have increased that facial height a little bit, which isn't my main objective, but that was only my preparatory work. I haven't really got going with the main bulk of work I'm going to do yet.
What do you do on that?
I use a head brace that I will show you later on. Yeah, so I really just use a reverse pull head brace, and what I'm doing now with the maxilla is I'm opening and closing and opening and closing and going on for about a year doing that with various other things. And I think if I could work on her body posture as well, I think I'd really accelerate it. But now I'm going to be a little bit arrogant. I think I'm getting the best facial changes ever achieved on the planet.
You are.
Ever.
You are. Look at that.
Yeah, I clearly am.
You are.
And, you know, I've quite a lot of, you know, I'm open to challenge on that. You know, come and show me your results. And I've said this many, many times, and I've had some people from this group have taken me up on the challenge, and they've set down their great cases, and they've got some great looking faces, but they look great to begin with. And so, what's the point? I've got some, well, we really are changing faces. And that's my, you know, from what I'm saying, my philosophy here is unless you can get that up and forwards, unless you can get facial change, well, you're not improving much to me. Yes?
May I be ignorant and ask you what you mean by facial change here? Are you only
Right.
talking about...
Getting the maxilla up and forwards.
Is that what
That's
you're
it.
talking- is that what
Yeah.
you're thinking?
Well, now,
The whole shape of her head has changed.
yeah, exactly, I know. Yeah, but I'm looking at the face because I'm an orthodontist. All right? So I'm going to come on. I'm going to hit that more as we go. Now,
I'm not a dentist.
Helen.
I know that you have an arrogant side.
I know, and I fully understand
I
that.
would like you to know that Derek Mahoney, who lectures internationally, says that you don't get better faces than you get with portrait.
Yes. Yeah. I know. It is quite well known, and there's big people around saying the same thing. But till this point, to do this has been uneconomic. Literally uneconomic. That's why more people are doing. So my thing has been to take my father's charity and to move it forward to make it actually a business. Because people aren't going to do something that's uneconomic. It's been the amount of hours and time put in on these kids is just ridiculous.
I was just interested to see if you could transpose that into an adult as well, rather than through a growing place of the young person.
That would be fascinating, wouldn't it? Well, is it possible to change the adult facial skeleton? Yeah?
Right, it's worth saying, I've never treated, I think you said 8 millimetres.
8mm.
I've got a reputation for treating adult reverse anterior bites of about 4 or 6 millimetres, so it can be done.
Yeah, well that's what so you were saying you can reverse adults. So I could repeat these things. Okay, so this is the multi-million-dollar question because I've not been advertising doing adults. I've started to see if I can do them, but of course people are finding me. I know the value of social media and the internet, and we've built up the largest social media empire in dentistry by some margin. Possibly one of the largest in medicine. I mean, bigger than, you know, your brand names, Pfizer's, GlaxoSmithKline Beecham. You know, we have a bigger social media empire than them, with the point of getting these messages out there, with the point of really engaging with people. So I'm engaging directly with the public. I'm engaging directly with the orthodontists and the dentists around the world to try and, you know, I want the truth. Now, well, we know we can adjust the adult facial skeleton, don't we? There's no question. We all know you can change it. Watch someone who's had a road traffic accident and damaged both facial nerves. Their face will literally melt away a little bit like a waxwork model that's got too close to the fire. And that's it. Now, doing me. But of course, I think, I was interested in Tim saying that the hips were the keystone. Of course, I clearly see the maxilla as being the keystone. And that is a great point for debate, and it's a great point of discussion. I like it when I find out that we have difference of opinion, and there's nothing better I like than being proved wrong. Nothing. Because that gives me so many possibilities. Yeah, you need to have belief. You need to have this little bit of arrogance to literally live in this world that we live in, where to some degree we are the persecuted few. But to be wrong is a pleasure. It has to be. Now, really, if we're going to try and get people back there, he's doing a Mackenzie chin tuck. So, you know, lots of people over history have had these same thoughts. We've all been seeing the same elephant from different angles, but we need to work out exactly the shape and nature of that elephant. The elephant in the room. We need to uncover it. Come out the closet. See what's happening. So if you try and get back, of course, he's going to struggle because he's now pushing his tongue down in his airway. Unless you can get that maxilla up and forwards, the mandible will just hinge. It's a hinged joint. Because remember, I can stand up straight if I need to, because nearly all of the joint surfaces within my body have a range of motion that will allow most of my bones, except some in my hip and some in my skull, of moving. These ones are tightly fused. Or not fused, tightly, they have a lesser range of motion. The ones, all the rest can do it. But if you ask someone to stand up straight in the right posture, they've got the angel on one side saying, now, Michael says stand up straight. This is the right thing to do. Wonderful. And the devil on the other side saying, breathe. And what's going to win at the end of the day? They're going to want to breathe. That's it, breathe. Of course they're going to fail. Because unless you can get that maxilla, I'm here. You know, I don't know what's going on down here. That's not my area. So unless I can get that maxilla up and forwards, we're never going to cure them. And really, we've got these people here who are going to die 10 years younger from sleep apnea. And CPAP will make them worse. Mandibular advancement splints will make them worse. The only really thing is to get an upswing of the face, either by surgery, usually double jaw surgery, or if we could do something else.
Sorry, Michael, why is CPAP going to make them worse?
CPAP, well, look, there's the thing on the face. It's the seal on CPAP always pulls back. All research shows that the long-term use of CPAP will pull the face back and down. It's a force.
It's somebody that age, 60 years old plus?
I have a stroke, 80 years old. No difference, just slower.
Are you saying the skull also moves back?
Well, the research is clearly suggesting this, and you suddenly see all these CPAP machines coming out now. They're claiming not to put too much force on the maxilla. Wonder why that is.
What about the second one? What about the
Mandibular advancement splints are much worse.
Because
Well, do you remember that bloke Newton? He wasn't wrong. There's an equal and opposite force. If you hold the mandible forward, you're going to hold the maxilla back. And you know what's going to happen in the long term? Treating symptoms, underlying, worsening the underlying problem. Sorry, it's just, I didn't make it up. Sorry. Now, so here we go. So I've drawn from Matani, I've drawn from Howell, I've drawn from Amir. It's important to recognise the people you've drawn from. Now, the idea is to get that maxilla up. And if you can get the back of the maxilla up, because it's easy to take the front maxilla forwards, pull forwards on the maxilla and make someone class 2. But then you've got to deal with class 2. But if you can lift the back of the maxilla, and remember, all the 3 joints at the back of the maxilla, where the maxilla or joins the, where the septum meets the sphenoid, where the palatines on either side meet the sphenoid, they're all sliding joints. Interesting, isn't it? But they're probably the shock absorbers, the suspension system at the back of the maxilla, as it's supposed to eat your chicken bones. We should eat chicken bones. We should always do that. You know, whenever, you know, I meet a parent, particularly from Afro-Caribbean origin, who walks in with this fantastic facial form, no malocclusion, I say, do you eat your chicken bones? Yep. Anyway, you're eating your chicken bones. So if you can push the back of that maxilla up, well, then the mandible will rotate up, won't it?
Hang on, you're talking about the back of the maxilla up.
So what you do is this. So as you move it forwards, you do that. Effectively an auto-rotation. You upset the back of the maxilla, then the mandible rotates forwards. So you don't have to worry about...
No, wrong way around.
Yeah.
You need the front of the maxilla up, so the mandible can come forward.
no, sorry. We'll sit down with a piece of pen later if you want.
I'll be there.
Yeah, you can prove me wrong if you want.
So will I.
So you take, if you just do that, you're going to stop on your molars. Well, if you do that, you rotate up.
You mean leveling it?
And you do vertical height as well.
No, I want to reduce vertical height. Every time I want to reduce height. I never want to increase vertical height. So anyway, are we getting any changes?
So which comes first, width or height?
What I'll be doing is widening and contracting. So I need to make width so I can get more space for my tongue. I need to lift it up so I can get more space for my tongue.
Yeah.
I need to move it forwards so I can have more space for my tongue. So then my tongue, rather than being here, can get out, stand up nice and straight, and hold that maxilla up.
That's correct, but do you need the width first?
Details, sorry. So we're working on this.
Okay.
And there's no firsts or seconds at the moment. I'm just seeing whatever I can get. Yeah. So now, 3 months later, I've seen her since, and it's as clear as mustard now. You know, this is someone, you know, I've been really looking at this with a friend to see if that could be lighting effect or changes. Sorry, I've seen her since, there's no question. And I'm getting them all back in. And everyone who's going the distance, I'm getting notable facial changes. Notable facial changes. And I've not even got going with all of the other bits and pieces. So I want to make together a team. So I want my cranial osteopaths, craniosacral people in. I've got Ian, who's in from NCR. We've got Keith here, who's from Rolfa. We've got Matt over here, who's from the Atlas Prophylax group. I'm going to get every gadget I can from the book. Yeah? I want to pull them all in. I want to get the GoPEC system, a guy in Australia, one of our orthotropic guys, who's teaching people to sit up straight at dinner, eat properly, do a 10 to 20 minute task every single day for 30 days, and you build up a neural processing. 30 days in a row, you'll build up neural processing. Then the 1001 small steps. You know, there's those 5-toe shoes, hard beds, looking at the workstation, exercise. You know, my idea is to build up a program, and I'm going to build it. It's going to be a big ticket item. I'm going to want to charge £10,000, £20,000 a shot. I'm going to take a limited number of patients. They start on a certain day together for those 10 places, so that I can work with a team, and I have an in-house team. And I want the majority of that going on the science. So I want to really screw all my colleagues down price-wise so we can focus on science. So I can have a 3D scan of the teeth and the face and the neck and shoulders every single time I see them. Every time. So I can build up real-time research so we can find the answers, so we can really put something in. Because without someone doing this, someone putting a team together, well, we're never going to know. I will go 3 more generations of my family without the answers. That is not going to happen. Now, of course, well, there's always those little things out there that make you stop and think, well, what's going on? Because remember I said I don't want to increase the vertical dimension ever. Well, of course, then I listen to Brendan Strack. And I get the Starecta guys coming over from Italy, if you've heard of them. Well, they came over, they sat, we had a chat. I want to know what they're doing. They're massively building up the vertical dimension. Now, it's interesting. So Brendan's looking at Tourette's, movement disorders, TMD, Parkinson's. Any else I've missed out? Mainly what he's doing. And he literally, people are standing up out of wheelchairs and walking. Now, some people say, well, that's the white coat effect. He's a certain individual that brings this about. But, you know, I know lots of people. You know, lots of people even in this room I've known since I was a kid. It's crazy, really. And they're telling me they've got the same results. And something, there must be something here. And the Starecta guys are treating scoliosis. Well, it's all of these things are crossing back on each other. Now, here's, you know, that he's clearly built up his facial height here. And, you know, this seems to be getting better, this scoliosis. But then there's other things that don't fit in, because, of course, you've got the work of Dahl. Of course, now Dahl was doing these things where they were opening the bite up. So you see here that the bite's completely, this tooth's over erupted. So they put in a splint of just, you know, I think they call it student metal. And then the bite closes back again, with the tooth going down. And so this was the sort of work of Dahl. And Dahl did some X-ray work to realise that, as a general rule, if you were 20 years old, you got some increase in vertical dimension. But if you were 40 years old, after 5 years, it all returned to normal. You ended up with exactly the same vertical dimension after 40 years you had in the first place. Now, these were high force groups. Clearly, you wouldn't wear your teeth out if you were a low force group. And you can't do this again because you can't take X-rays every year or whenever you fancy, and you can't put tyrannolallium implants in people. So we can't really go, but it does seem to say that, well, if he's right, then 5 years later, all of Stack's guys, who has opened up the bite, all of the guys that the TMD people, where they're opening up the bite, that have got strong muscle force, that are in that later age group, they're going to have the same vertical height that they had in the first place. So how have you affected them? What's going on? So I'll stay there for a second. So, but I was fascinated. I was sitting there really, really, really trying to understand how Brendan Stack might be getting the results. I was absolutely fascinated. You know, is it, you know, if you're overclosing, is that messing up the Golgi tendon organs or the muscle spindles? Is the jaw opening moving into, you know, the auricular temporal nerve or that little artery there?
A lot of these patients have got damage in the joints. The joint space is closed because the disc tissue is out of position. So he's creating height in the TMJ by increasing the distance between the upper and lower teeth at the back. So it's a decompression and a realignment, which is also allowing the temporal bones to get into a less compressed position.
Yeah, you know
that's the reason that the height increase takes the pressure off so many of these.
That may be the reason. That may be. So that's what we've got to be very aware. And I'm only putting up maybes here. And we need to sit down and possibly go through that. But that may well be, but we don't know. And what we do know from some very good science and research here is there's a good chance that 5 years down the line, the actual vertical height, so maybe the actual compression, I don't know what's going on, may be exactly the same.